leg has three compartments of muscles: the anterior compartment, the lateral compartment, and the posterior compartment. These are the three compartments of muscles in the leg. So it is always very good for us to represent these muscles in tables because they are easy to understand. And the other issue is for us to appreciate that when the sciatic nerve reaches the popliteal fossa, don't know whether you know what the popliteal fossa is. The popliteal fossa is this region posterior to the knee joint. It is diamond shaped. I want us to this region posterior to the knee joint is known as the popliteal fossa. So we saw the sciatic nerve entering the gluteal region and coming down to the thigh, then it comes to the popliteal fossa. So this diamond-shaped region, posterior to the knee joint, it is the popliteal fossa. So when the sciatic nerve reaches the popliteal fossa, it divides into its two portions separate. It is the sciatic nerve. When the sciatic nerve reaches the popliteal fossa, its two portions separate. The common peroneal goes lateral, and the tibia remains posterior like that. So this is showing us the two divisions of the sciatic nerve separating in the popliteal fossa. The common peroneal is the one which is lateral, and the tibia is the one which is medial. This common peroneal portion of the sciatic nerve is going to come laterally and wind around the head of the fibula, as you can see. It's going to wind around the head of the fibula. So when you have injuries from the lateral aspect of the knee, those injuries can damage the common peroneal nerve. So when it separates from the tibial portion of the sciatic nerve with the popliteal fossa, the common peroneal comes laterally and winds around the head of the fibula. And when it winds around the head of the fibula, it divides into two portions. A superficial branch, which is supplying muscles of the lateral compartment, and an a deep branch. This is not anterior, but it's a deep branch. The deep branch is going to come anteriorly and supply the muscles of the anterior compartment. So this is our sciatic nerve in the popliteal fossa. The common peroneal portion separates from the tibial portion. The common peroneal portion comes and winds around the head of the fibula, and it is where it is commonly injured. If you have trauma from that aspect of the knee, and when it winds around, after it winds around the head of the fibula, it divides into a superficial branch which supplies muscles of the lateral compartment, and then a deep branch which supplies muscles of the anterior compartment. The tibial portion which remains posteriorly is going to supply muscles of the posterior compartment of the leg. So those are the three muscles. Those are the three nerves. The superficial branch of the common peroneal nerve supplying muscles of the lateral compartment of the leg. The deep branch of the common peroneal nerve supplying muscles of the anterior compartment of the leg. And the tibial portion of the sciatic nerve supplying muscles of the posterior compartment of the leg. So these are the muscles of the anterior compartment of the leg. And as you're seeing, they are supplied by the deep branch of the common peroneal nerve. Now, the common peroneal nerve sometimes is known as the common fibular nerve. So those names are used interchangeably. Sometimes they use the word common peroneal, sometimes they use the word common fibula. They are referring to the same nerve. So the deep branch of the common peroneal nerve, you see, it's the nerve which is supplying the muscles of the anterior compartment, as we have seen here. And those muscles are indicated here. The tibialis anterior, the extensor digitorum longus, the fibularis tertius, and the extensor hallucis means that it's going to perform its actions on the toe, the big toe. Hallucis means the big toe. Okay, so these are the four muscles of the anterior compartment of the leg, and the tibialis anterior dorsiflexes. To dorsiflex is to lift your foot up. And when you dorsiflex, wherever you are, when you dorsiflex, you're going to sense the muscle, that muscle, tibialis anterior contracting. And to invert is to make sure that the sole of your foot faces medially. The sole of your foot faces medially. So these are the two actions of the tibialis anterior. And these are its origin, and the insertion is here. The medial cuneiform bone is a bone of the foot. Now I want you to go and study the skeleton of the foot, because if you do not study the skeleton of the foot, you will not know what the medial cuneiform bone is, and the base of the first metatarsal. That is why I've been telling you that these origins and insertions are very important for you to understand or to study the bones of the limbs. So if we say medial cuneiform, have you seen where that bone is? What do we mean by a base of a metatarsal and a head of a metatarsal? What do we mean by metatarsal number 1? A student who is aggressive to study will go and find out what these bone landmarks are, where the muscle inserts. And then the lateral condyle of the tibia gives us its origin. So that muscle is here. Tibialis anterior is the superficial most. Tibialis anterior from the medial condyle of the tibia, and it comes and inserts around here. We have a bone there known as the medial cuneiform and metatarsal number 1. And this muscle, when it contracts, you dorsiflex the foot. When dorsiflexion means that you lift it up. That is our muscle known as tibialis anterior. We are on muscles of the anterior compartment of the leg. Deep to it, there is a muscle known as extensor digitorum. In other words, when you stretch out your toes, you're extending them. That's why they call it the extensor of the digits, extensor digitorum. You stretch out your toes, and you see it is extending the metacarpal phalangeal joints of the digits. The nerve to these muscles does not change, and it's also having an origin from the medial condyle of the tibia and part of the fibula. The lateral condyle of the tibia, not medial, and part of the fibula, because the fibula is also lateral. And this is inserting to the phalanges. Okay, it is inserting to the distal phalanges. Number 2, number 3, number 4, and number 5. Each tendon is divided into 4 and is insert on the distal phalanges number 2, number 3, number 4, and number 5. When we go back to this is our muscle, extensor digitorum. You can see the 4 tendons. It sends no tendon to the big toe. So when we want to see our extensor digitorum, let's look at this one here. This is our extensor digitorum. It's sending tendons to the distal phalanges of digit number 2, number 3, number 4, and number 5. Very, very important muscle. Stretches out the digits. Stretches out the digits. And when they stretch out, that is extension. Acting on those joints between the metatarsals and the phalanges. The word fibularis can be replaced by the word peroneus. So the muscle known as fibularis tertius is the same as peroneus tertius. Depends on the textbook or the author. And this muscle is very important in eversion. Eversion is the opposite of inversion. Inversion is when the sole of the foot is facing medially. Eversion is when the sole of your foot is facing laterally. And it is originating from the fibula and inserting on the base of the fifth metatarsal. Now, this is the one which stretches out the big toe, extensor hallucis. From the fibula to the distal phalanx of the big toe, it extends the big toe. Extension of the big toe means that it stretches it out. Of course, this is the muscle deep layer extensor hallucis, but that muscle deep layer extensor hallucis, and you're seeing that it is taking its tendon extensor hallucis there, and its tendon is going to the distal phalanx of the big toe, and when it contracts, the big toe is extended or stretched out. So it is very important for us to appreciate these muscles very well. And now fibularis tertius is this one, originating from the anterior surface of the fibula and it's coming to insert at the 5th metatarsal there. It's known as fibularis tertius. The other name for fibularis tertius is peroneus tertius. So those are our muscles for the anterior compartment of the leg. And when you look at the ankle joint, the tendons of the muscles of the anterior compartment of the leg pass anteriorly on their way to insert on the foot. And we shall see the tendons of the muscles of the posterior compartment of the foot of the leg will pass posteriorly to the ankle joint, and the tendons of the muscles of the lateral compartment of the leg will pass laterally. So their positions as they are crossing the ankle joint are related to their compartment. If a muscle is a muscle of the anterior compartment, its tendon is going to pass anterior. If a muscle is a muscle of the lateral compartment, its tendon is going to pass lateral. If a muscle is a muscle of the posterior compartment, its tendon is going to pass posterior to the ankle joint. Now, I said that this muscle, tibialis anterior, dorsiflexes. To dorsiflex is to lift your foot. When I say lift your foot, some people are going to lift their entire limb. The foot is that part distal to the ankle joint. This is the foot. So when you elevate your foot, you are dorsiflexing. And that dorsiflexion is the action of this muscle known as tibialis anterior. And tibialis anterior is supplied by the deep branch of the common peroneal nerve. If this deep branch of the common peroneal nerve is injured here, the tibialis anterior is going to paralyze. You're not going to be able to dorsiflex your foot, but instead your foot is going to drop. Because the muscles which are plantar flexing, plantar flexion is the opposite of dorsiflexion. When your foot is facing downwards, you're plantar flexing. And the muscles of the posterior compartment of the leg are responsible for plantar flexion. But when you lift it, you're dorsiflexing, and that is tibialis anterior. So tibialis anterior is paralyzed because the common peroneal nerve, its deep branch, is injured. So you cannot dorsiflex. So the plantar flexors are going to pull the foot downwards to plantar flex. And when the foot drops, we call that condition foot drop, because you cannot dorsiflex due to injury of the tibialis anterior muscle. The lateral compartment of the leg is made up of two muscles, peroneus of fibularis longus and peroneus of fibularis brevis. They have a common action of everting the foot. Eversion of the foot is when the sole of the foot faces laterally, and that is why these muscles are lateral. They can cause eversion of the foot where the sole of the foot is oriented laterally. But fibularis longus has another action of plantar flexion. This plantar flexion is an action of the muscles of the superficial layer of the posterior compartment. But fibularis longus can also perform it on top of eversion. Now, the muscles of the lateral compartment of the leg are supplied by the superficial branch of the common peroneal nerve, which we saw. And these are their origins and the insertion. Fibularis longus, because it is longer, originating from the lateral condyle, and fibularis brevis originating from the lateral surface of the fibula. The medial cuneiform, this muscle, fibularis longus, originates from the lateral condyle, but it goes below the foot and goes up to the medial cuneiform and the first metatarsal and inserts there. I don't know whether we have that muscle here. So you can see this muscle fibularis longus from the lateral condyle of the tibia and the lateral surface of the fibula. You can see this muscle passing lateral to the ankle joint. It goes below the foot like that and comes and inserts at the medial cuneiform bone and the base of the first metatarsal, fibularis longus muscle. So the illustrations are really giving us the best picture of that muscle. It can plantar flex, but it can also evert the foot. And fibularis brevis, lateral surface of the fibula, and it inserts at the tuberosity of the fifi metatarsal. And our illustrations have shown that muscle there, fibularis brevis, and its tendon comes with the tendon of the peroneus longus, and inserts at that is the muscle, Quadriceps brevis. Its tendons come deep to that of the longus, and then it comes and inserts at the base of the fifth metatarsal. There's a tubercle there where it inserts. Those are the two muscles of the lateral compartment of the leg. You get more images to help you. Now, the posterior compartment of the leg has muscles which are made up of two layers. The muscles on top form the superficial group, and these muscles have a tendon known as the Achilles tendon or calcaneal tendon. Their tendons come together to form the calcaneal tendon. Those are the muscles of the superficial layer. And the muscles of the deep layer are deep to these other muscles, which are superficial. So these are the two groups of muscles in the posterior compartment. The superficial layer is made up of three muscles: gastrocnemius, which has two bellies. Deep to gastrocnemius is a flat and big muscle known as soleus. The tendons of these two muscles come together and form what you call the calcaneal tendon, which inserts in the calcaneum. Then there's a small muscle known as plantaris. Its tendon joins the tendon of these two muscles, which will insert in the calcaneal bone. And they are supplied by the tibial portion of the sciatic nerve. They are plantar flexors. They are opposing tibialis anterior. So these muscles origins are indicated there, and they insert in the calcaneal bone of the foot. And the gastrocnemius has a medial belly and a lateral belly. The lateral belly originates from the lateral condyle of the femur, and the medial belly originates from the medial condyle of the femur. So this muscle gastrocnemius has two bellies. The soleus originates from the soleal line of the tibia, on the posterior surface of the tibia. And these landmarks are very important for you to appreciate. So these are the two bellies of gastrocnemius, from the medial condyle and lateral condyle. Then this is the soleus deep to them, which originates from the posterior surface of the tibia and the soleal line. And then this is the plantaris, which originates from the medial condyle. These muscles come and form the calcaneal tendon, and the calcaneal tendon is also known as the Achilles tendon. You can touch it. You also have that tough strand at the back of your foot, and the calcaneal tendon is going to come and insert on the calcaneum. These muscles are supplied by the tibial component of the sciatic nerve, and their action is to plantar flex, opposing the action of tibialis anterior. So you can see that two gastrocnemius muscles, when you dissect them away deep to them, you have the plantaris and then the soleus. And that is the Achilles tendon or calcaneal tendon inserting on the calcaneum. So the muscles, the tendons of muscles which contribute to the calcaneal tendon, we have the tendon of gastrocnemius, the tendon of plantaris, and the tendon of soleus. The calcaneal tendon can rupture. It can be as a result of trauma. Something can cut through it and rupture it. Okay? It can be as a result of inflammation. So, when this calcaneal tendon ruptures, the muscles of the superficial layer of the posterior compartment of the leg are detached from their insertion, and they contract by moving upwards. They contract by moving upwards. And you're going to see a bump on the posterior compartment of the leg, because when these muscles are separated from their tendon, they contract upwards and then they form a bump, a bulge, in the posterior compartment of the leg. And it can be operated on surgically, but sometimes it is non-surgical. They approximate the tendon, they bring the two parts of the tendon closer to each other, and they give them time to regenerate. But if it's to heal quickly, they can operate on it. Then the muscles of the deep layer of the posterior compartment of the leg are these muscles, popliteus, because it is attached at the popliteal surface, which is on the posterior aspect of the knee joint. Flexor digitorum longus, which opposes the extensor digitorum longus of the anterior compartment. Flexor hallucis longus, which opposes the extensor hallucis longus of the anterior compartment. Tibialis posterior, which opposes the tibialis anterior of the anterior compartment. And as you see, this is the tendon calcaneum or the calcaneal tendon, which is a tendon of the superficial muscles. Now, deep are the tendons of the deep muscles of the posterior compartment. So the posterior compartment of the leg has superficial muscles, which form the calcaneal tendon, and the deep muscles whose tendons are deep to that of the calcaneal tendon. So they are also supplied by the tibial portion of the sciatic nerve, and you can see that the flexor digitorum longus flexes the distal phalanges of the lateral 4 digits, digits 2, 3, 4, and 5, opposing the extensor digitorum longus. Flexor hallucis longus flexes the big toe, opposing extensor hallucis longus. And then tibialis posterior, this one inverts the foot. By inversion of the foot is when the sole faces inwards. And this popliteus rotates the tibia medially and the femur laterally. When you're standing, when you are in a standing position, if your knee joint is to become stable, it locks itself. Locking of the knee joint refers to the medial rotation of the tibia and lateral rotation of the femur. That's what they call locking of the knee joint. And this is the action of this muscle known as popliteus. The origins are indicated clearly here for you to read and understand the osteology of the bones, and the insertions are also indicated at the same time. So this is our muscle popliteus, the flexor digitorum longus, the tibialis posterior, which everts the foot, and the flexor hallucis longus, as indicated here. Now, the foot, this is the skeleton of the foot. This is the skeleton of the foot. And when you look at the medial aspect of the foot is arched. This arch is what we call the medial longitudinal arch. It is known as the medial longitudinal arch. And laterally, it is also arched, and this is what we call the lateral longitudinal arch. And then even transversely, it is arched, and this is what we call the transverse arch. So the foot is arched so that because the ground on which you step is irregular. God created the foot not in relation to the shoes you're going to wear, but because the ground was irregular. And this arched foot makes you stable on the ground. So the medial longitudinal arch is made up of this bone known as the calcaneum. The medial longitudinal arch is made up of this bone known as the calcaneum. It is made up of this bone known as the talus. This is the talus. Then this bone known as the navicular. And then here we have three bones known as cuneiform bones. This is the medial cuneiform bone, the intermediate cuneiform bone, and we have a lateral cuneiform bone. Then it is made up of these bones, the first, the second, and the third metatarsals. So the bones which make the medial longitudinal arch, we have the calcaneum, the talus, the navicular, the three cuneiform bones, the medial, the intermediate, and the lateral, and then metatarsals 1, 2, and 3. Those bones form the medial longitudinal arch, and it is higher than the lateral longitudinal arch. Then the lateral longitudinal arch is made up of these bones, the calcaneum, the talus, meaning that this talus forms both the lateral and the medial. The calcaneum also forms the lateral and the medial. So the lateral longitudinal arch is also formed by this bone, the calcaneum, the talus, the cuboid bone, and metatarsals 4 and 5. These bones are the ones which form the lateral longitudinal arch. But as you see, the medial longitudinal arch is more raised than the lateral longitudinal arch. And the medial longitudinal arch has more bones than the lateral longitudinal arch. When you count them, the calcaneum is number 1, the talus is number 2, the navicular is number 3, the 3 cuneiform bones form 6, and then the 3 metatarsals 1, 2, and 3 form 9, made up of 9 bones. Whereas the lateral longitudinal arch is made up of the calcaneum, which is 1, the talus, which is 2, the cuboid, which is 3, and then the 2 metatarsals 4 and 5, which is 5 bones. So the medial longitudinal arch is made up of 9 bones, and that is made up of 5 bones. Then we have this transverse arch. The transverse arch is made up of the cuboid bone and the 3 cuneiform bones. The cuneiform bones have the lateral, the intermediate, and the medial. So the cuboid bone, the lateral cuneiform, the intermediate cuneiform, and the medial cuneiform, then the bases of the metatarsals. These are the bases of the metatarsals. Let's see. The bases of the metatarsals forming the transverse arch. So the 3 arches of the foot are the medial longitudinal arch, the lateral longitudinal arch, and the transverse arch. The transverse arch is made up of the cuboid, the 3 cuneiform bones, and the bases of the metatarsal bones. And these arches are compatible with the irregular ground on which we stand, and therefore they stabilize us when we are standing. There are many factors which cause these arches not to collapse, because if you walk for longer distances, the arches are going to collapse and you're going to have a flat foot because of the collapse of the arches. And what is causing the collapse of the arches? What is causing the collapse of the arches is the weight which has been standing on those arches for a longer distance. And then when those arches collapse, you sense pain within the foot. But what factors lead to the stability of these arches such that they do not collapse? You have ligaments which are joining these bones. These ligaments are making sure that the bones are held tightly so that they do not dislocate. So those are intertarsal ligaments, that the ligaments between the tarsal bones fix those bones together that they do not collapse, and that is one of the factors which causes the stability of the arches. Then we have been seeing the tendons which insert on the foot. These tendons which insert in the foot. When these muscles contract, the tendons pull upwardly. The tendons pull upwardly. And when the tendons pull upwardly, they raise the arches so that the arches remain suspended. Then the bones themselves are wedge-shaped. These bones are wedge-shaped. When I say that the bones are wedge-shaped, they are like these interlocking bricks. They fit into each other. So these bones are wedge-shaped, so they fit into each other, and that wedge shape is one of the factors which stabilizes those arches. And then you have long plantar ligaments. Ligaments, there's a fibrous, dense connective tissue on the inferior surface of the foot, on the sole of the foot, known as the plantar aponeurosis. The plantar aponeurosis is attached at the calcaneum and then at the heads of the metatarsals. It stretches from the calcaneum to the heads of the metatarsals. In other words, it keeps the two ends of the arches in position. The plantar aponeurosis keeps the two ends of the arches in position because it is attached at the calcaneum and at the heads of the metatarsals, keeping those two ends of the arch in position so that they do not slide away, so that you get a flat foot. The joints of the medial longitudinal arch will have this joint, the subtalar joint. They call it a subtalar joint because it is below the talus. And this is the joint between the talus and the calcaneum. It is known as a subtalar joint. Club foot always affects the subtalar joint. Then you have the talonavicular joint between the talus and the navicular. Then you have the navicular cuneiform joint between the navicular bone and the cuneiform bones. Then you have the metatarsal cuneiform joints between the metatarsals and the cuneiform bones. And the joints of the lateral longitudinal arch will have the subtalar joint still, the calcaneocuboidal joint between the calcaneum and the cuboid. Then we have this joint between the cuboid and the cuneiform bone. And then we have another joint between the cuneiform bone and the metatarsal joint, metatarsal cuneiform joints. I want you to go and read about these arches again, the bones which contribute to those arches, the joints within each of the arches of the foot, and the factors which lead to their stability.